Welcome to this episode of Growth Island. My name is Mads Friis, and as always, I got the pleasure of being your host. Today's episode is with an expert on mental health. He has a bachelor, master, and a PhD in neurobiology. He is also a medical doctor, and even bigger, he has been a professor and emeritus professor at the University of Southern California in the medical department. He will share today about some of the cutting edge research and how we're actually seeing new treatments within mental health that are going to revolutionize the way that we treat people. We're talking about psychedelics, we're talking about ketamine, we're talking about something called TMS that are showing amazing results. This guy, David Feifel, I can tell you he is a powerhouse, and it's one of my longest episodes because he was so fascinating. We also talk about the health research in general and how we can know something is true or not. So this is really an episode you don't want to miss. I'll see you there. So David, thank you so much for coming on the show. Now we had a brief discussion before, and I've really been looking forward to having the chance to pick your brain on this stuff. Both being like having a bachelor, a master, and a PhD in neurobiology, and then doing a medical degree as well to be a medical doctor. Like, how did all this come about?
I just at some point in high school, I went from being sort of kind of a dopey troublemaking kid who liked to pull pranks and just have fun to I got intellectually very stimulated, and I think from then on I just loved learning. I couldn't inhale books quick enough, and I was very. I actually got my entry point into all this was the issues of time and quantum physics and consciousness. And so to me, going to school was like I couldn't think of doing anything better, making your brain grow stronger. So it was all it's people tell me they couldn't wait to get out of school, and I was like I looked for excuses to stay in school and learn more. So I guess it's different people have different kind of pleasures.
That's fantastic. And how did you learn about ketamine and transcranial magnetic stimulation, if I'm pronouncing it right? Like, how did you go from the education and being like, okay, there's something interesting here?
Well, I decided to go into psychiatry because I was fascinated with the mind, and when I was at University of California, San Diego, and as a faculty member there, professor, my kind of job was to treat people with very severe mental illness, and I also was doing research. I was a researcher, and I had a lab where we were doing studies, basic studies, with animals, looking for new treatments. And doing clinical trials with patients, and generally I was disappointed. I would say I was disappointed with my field because here we had this incredible societal problem of mental illness, and it was growing in prevalence. I think today, the World Health Organization ranks depression as the number one source of disability globally. It's kind of risen over the years. So it had this remarkable medical problem, and I saw people suffering with depression and with schizophrenia and OCD, and I was really disappointed that the tools we had didn't seem up to the challenge. I felt like I was on the front line trying to fight a war against a very powerful enemy, but I was I had a fork or something. I don't know. Just didn't seem right. And at the same time, I was also looking at what other specialties were accomplishing. And I was seeing people, go to orthopedic surgeons and get a knee replaced, and in a few weeks, we're like good as new. And so I was a little envious of this, and it was interesting because the science was great. As brain sciences was flourishing, we were developing all these powerful ways of looking at the brain and seeing how it's working, but we weren't really translating it into new treatments. The medications that we had, the conventional medications, really didn't differ much, and it's true to this day, didn't differ much in their mechanism of action from the very first ones that came out in the 60s, which were discovered by serendipity. So yeah, they've changed in some ways. They have less side effects, but in terms of their mechanism of action, they haven't really evolved much. And it was, in fact, there was a very famous or well-known editorial in the New York Times by a psychiatrist named Robert Friedman. I think it was around 2011. And he was talking about the crisis in psychiatry from the lack of new medications being developed, new treatments being developed. And a lot of companies, pharmaceutical companies, were actually closing their CNS divisions because they were just not able to come up with anything new. Drugs are good for a while they're on patent for pharmaceutical companies. Once they go off patent and there's a generic one, it doesn't make a whole lot of business sense to develop a new one, because the insurance companies will want the patient to go with the older one if it's essentially the same. So there was a need to develop something first in its class, new, that can be a new source of revenue, and companies were spending millions trying to look at new targets, new targets in the brain that would bring better treatments, and they were just flopping. So they were kind of withdrawing and looking at in other areas. So we were stuck in the mud. We didn't see anything down the horizon, and then a couple things happened that were I sensed might be. They didn't seem very much at the time, but I sense could be the beginnings of sort of something really important if they were were to evolve as promising as they were. One of them was the development, which I was tracking, of this new treatment approach called Transcranial Magnetic Stimulation, which is one approach in a bigger, let's say, field of a treatment called neuromodulation. The idea of modulating the brain activity, especially non-invasively. So TMS is this the idea behind TMS is the ability to selectively target areas of the brain that we have learned are not functioning optimally in a certain disease, and each disease would have different areas of. For example, in depression, one of the common areas that we see underactive is on the left side towards the left prefrontal cortex, and we know that plays an important role in a lot of things like regulating mood, and it's connected to some of the deeper emotional centers like the pleasure center. So TMS is this tool that allows us to target that area very selectively and stimulate it, do like physical therapy for that area, and over time strengthen and correct it. Whereas previously we were doing this in a very let's say crude way by taking a pill, dropping it into our stomachs. It gets absorbed throughout the blood circulation, so it affects all the organs that have receptors for that, because a lot of the chemicals, neurotransmitters in the brain also exist in the body. So you get these side effects, and then it crosses over into the brain, and it basically goes everywhere in the brain, causing effects that we're not necessarily wanting, all to kind of change firing of the neurons, the brain cells in a particular area. And we have 84 billion brain cells that are always firing and talking to each other, but they're regulated by these chemicals. So it's kind of a very indirect way, and you can understand why that approach would be not always so effective. And a lot of people just didn't, they would try 1, 2, 3, 4 combinations as well of medications, and none of them were helping. So there's for many people they did help, but there was a large proportion of people, at least a third, got no benefit, and many of the other 2/3 got some benefit, but partial. So there's a lot of people who just weren't benefiting. So here we had this technology that was able to kind of go right to the target and exercise it, and very few side effects. So I was tracking that. In 2008, the FDA approved the first device to do that, and I kind of jumped on it, and I kind of spoke to my the chair of our department. And I convinced him that we must get one of these if we're to continue to be like an academic leader, a kind of a progressive department of psychiatry. At the time, he wasn't very convinced. He thought it was sort of some sort of esoteric treatment that wasn't really going to pan out.
Basically, TMS sends electric current into the brain, right? So stimulates. So
it actually sends a pulsing magnetic field. So there's principles of physics that go back to the late 18th century that were discovered, that if you have a pulsing magnetic field on and off, anywhere in proximity to something that can conduct electricity, you will induce current in that. So that's how kind of generators work. They rotate, wrapped wire, which creates a magnetic field around something and induce a current in it. So basically, it's just a pulsing magnetic field that will cause a select number of brain cells in its pathway to fire. So what we're doing is we are making those brain cells do what they normally do, but aren't doing it enough. And the analogy I give to people is, imagine you were in some sort of let's say a sports accident, and you tore your shoulder, let's say your rotator cuff, and you had to go to surgery, and you were in a cast, and basically, you had no strength or good range of motion. So that part of your body now is really underperforming. So you go to a physical therapist, and they make you do the kinds of exercises that part of those muscles would normally do. And they make you do it over and over again. And they're kind of, you wouldn't probably be doing it on your own. You probably avoid this kind of thing, but they teach you the right way to do it. And it's a slow process, but then you strengthen it, and you have full recovery. So that's sort of what TMS is like a physical trainer for the area of the brains that we choose to stimulate. And what's interesting about it, the same principle can be applied to different diseases. It's just different areas of the brain. So now, in America, TMS has now become approved for OCD, obsessive compulsive disorder, and more recently, it's been approved for smoking addiction, just within the last year. And each of these involves targeting different circuits of the brain that were selected because research has shown that those areas of the brain are involved in those symptoms, those conditions, and each of those, and the other interesting thing is we can actually turn up or turn down the activity of certain areas. So sometimes in a certain disease, there's excessive activity in an area, and in other diseases, certain areas might have lower activity. So I mentioned the brain on the left prefrontal cortex, we generally think is underactive in depression. And so we stimulate it to, over time, be more active. But let's say we were treating voices that people with schizophrenia hear. Well, the evidence suggests that might be due to overactivity, the parts of the brain firing when they shouldn't be firing in the auditory areas. So sort of the same areas that are making you able to hear my voice right now might be overactive in somebody with schizophrenia when there's nobody talking to them. So the best protocols for voices, auditory hallucinations, is targeting those auditory areas, but using a frequency of pulsing magnet that over time is going to lower it. So it's just a neat a neat tool that allows us to become much more sophisticated in how we are changing the brain than, let's say, conventional medication, which are non-selective. So we can choose the area, and we can choose what we do to that area based on how the abnormality is. And
so Peter, could we say, without oversimplifying it, but just what I'm hearing is kind of like what you said with working out, you could potentially work out a specific exercise. You do biceps. That's the part of the brain that needs to be exercised a bit more. So you work that out, like you lift some weights there, or you want the biceps to be more flexible, meaning that you need to down-regulate it a bit, then you do some stretching again. Or otherwise, you could take a growth hormone that affects the entire body, but you don't have the same control over those specific parts, which is what you do with normal antidepressants. And that can have a bunch of side effects because it doesn't just affect the place where you have the biggest challenge. Could that be kind of... That's
right. That's a good analogy. And I would add that it's not just that it affects everything, but it also, even in the areas that it is trying to correct, it's only working indirectly, because the firing, we've actually moved away from the idea of mental illness being a chemical imbalance, which the truth is, although you still hear people in the public think of it that way, the truth is, a little dirty secret, if you will, in neurosciences, that there's that's been debunked. We've not been able to find consistent abnormalities in these neurotransmitters in people with depression. A lot of patients will come to me and say things like, I think, my depression is, I take this supplement that's supposed to raise serotonin, and I've heard that, low serotonin causes depression. Well, the truth is, we don't see differences in the brains of serotonin levels in people with depression and people who are not depressed. Furthermore, we have the ability to actually deplete serotonin from healthy people. There are ways to do that by giving them elixirs to drink that have these large neutral amino acids that'll suck out all the serotonin out of their brain and their central nervous system, and they don't become depressed, And then the third piece of evidence that kind of debunked this whole idea that you have low serotonin and you're depressed, so therefore you take these drugs that boost serotonin. The third piece of evidence was that these drugs, like the Prozac and so forth, the SSRIs, that they will increase serotonin levels in the brain within hours, but their depression doesn't get better within hours, it's weeks. So we are quite sure that this notion of, just low levels of serotonin or dopamine is not as simple as that. We know that for a fact. But I think it's such a compelling story that you still hear that we're much more shifted towards the firing pattern and something called neuroplasticity, the ability of the brain to change, adapt to different situations and to learn, and that being more of the core function of the brain, and also when things go wrong, where those are. So
David, I'm gonna have to ask some follow-up questions for that, because that's it's been something that's been something I haven't been able to understand. I've been curious about, because there's so many things when we talk about health, we say like, this is how it is, and I'm often like, how do we know that that's the way? So basically what you're saying, because I heard the story that is serotonin that's often low, and then we need to boost that. But I also learned that around 80% of the serotonin production comes from the stomach, from the gut. I heard those numbers, something like that. So basically, you can work a lot more on that instead of just giving people pills. But I think you kind of answered similar my question that I've had for years is like, how do we know that it's a problem with serotonin up in the brain? Like, how do we get to that conclusion that people have too low serotonin levels in their brain, and thereby that's the reason for depression? Because that's what you're saying, that's not really the reason. So I'm like, how do we get to that conclusion in the first place?
Great question. It's one of those. It's an interesting story. It basically, like a lot of things in psychiatry, and I think also in medicine, we made a discovery about something that helps a disease. Mm-hmm. You know, something by accident we found, helps this disease, and then we said, what does that thing do? And we find that this thing, increases, X in the body, and then we have a theory, and it makes complete sense. The theory is, well, maybe the disease is a lack of that X, but that's just a theory, and then it has to be proven. So the story behind antidepressants is fascinating. In the earlier part of the 20th century, tuberculosis was, the COVID of its time. Certainly, at least in North America, they had these they call them sanatoriums, where people who were infected with tuberculosis would be sequestered, because they're quarantined, and they introduced this drug, really the first effective drug, called iproniazid. And it's very similar to the drug isoniazid that we still is the mainstay of treating tuberculosis. And iproniazid was found to be effective for tuberculosis. So they kind of started to use it in these sanatoriums. And you can imagine these are pretty miserable places with people a lot of depression and ill patients. And what they discovered was not only was it helping the tuberculosis, but there was a change in the mental status of people. People were perking up. And some people actually became manic, which is something we know that any drug that has mood elevating properties, and a certain percentage of people are going to flip them into, if they have that vulnerability, into mania, which is kind of let's say the alter ego of depression, where people are energized and they're talking fast and they're feeling great. And the doctors in these sanatorium were just totally perplexed. I actually found the New York Times article describing this in, I think it was maybe in 1958 or 1959. So nobody could understand, why is this drug having this side effect? Because up to then, the idea was, if you're depressed or something, it was much more of a psychological issue related to, your childhood and so forth. And it took years of therapy. And here's this, this compound, this chemical that suddenly is changing people's personalities, So they analyzed it, and they found that one of the properties that iproniazid had was that it blocked an enzyme called monoamine oxidase, and monoamine oxidase is the main enzyme in the brain that breaks down these chemicals called monoamines. And there's three chemicals that you probably heard about them, that are monoamines: serotonin, noradrenaline, and dopamine. They're very chemically related, and together they're called monoamines. And when they're released into the brain, between brain cells, monoamine oxidase goes and breaks it up. And there's another mechanism where they're also those that aren't broken down are swept back into the cell and recycled. But iproniazid blocked monoamines, so it raised the levels of the monoamines in the brain, because it prevented monoamine oxidase. So there, in the early 60s, there was this theory. It's called the monoamine theory of depression, that depression is related to low levels of monoamines, because this new treatment that we discovered, which then was the basis for antidepressants, like the first antidepressants, because these antidepressants that improve mood, what they do in the brain is they raise monoamines. So it was a very reasonable thing, and then it got focused more on serotonin because there was, we found that you could do the same thing in the brain with depression. I mean, treat depression just with drugs that increase serotonin and not the dopamine and the noradrenaline. So it's thought to be serotonin. But then this theory has to be converted into a scientific fact by studies, and the studies that were done, including the ones I just mentioned, didn't support it. But the idea was so compelling. When our brains, Mads, we don't like complexity, and we like to feel that we understand the world. And a good story is very hard to kill. So in the world of neuroscience, you couldn't go and talk about low levels of serotonin because you would have been laughed out of the room. But in the public, that story, and the media, that story persisted. And I think the pharmaceutical companies also were quite pleased to promote it because it helped people understand why they need their medications, which boost serotonin. But it's been many decades already that we kind of have put that to rest, that there's just the evidence just isn't there now.
It's incredible how long something like that can live on. And like you look it up and look like credible sources and so on, referencing it. But like, I think that's also the fascinating thing and why I'm so curious about the whole health space in general, like the things that we take to be truth. That's why my questions are often like, how do we know this to be true? Like, have we proven some kind of causality, or are we still at the correlation? Just like, as far as my understanding is, much of the stuff we know about the brain is, we know that different parts of the brain lights up. So that means that blood goes to that part. And thereby we say that's the part of the brain that is related to this, which makes a lot of logically sense. But that's as far as we've come to really prove that that's what happens.
Right. You are spot on. And you actually have hit on a sort of a pet peeve of mine. I hear colleagues will often, take findings and make that last leap, and then talk about something as if it's the actual effect. I know we're going to talk about ketamine. One of the things that people are trying to understand why ketamine works the way it does. One of the things it does is it produces something called neurogenesis. It will very rapidly stimulate new brain cells and brain cells that exist to create more connections. And that seems like that would be a very good thing, right? And that could be, maybe that's how it improves depression so well. And so I now hear, colleagues, and certainly well-read patients will come in and read this because the media will say, ketamine works through neurogenesis, but we've never proven that that's the causal thing. Here's the other problem: blueberries will do that. Yeah. but as good and healthy as blueberries are, we don't see the same kind of dramatic improvements in depression. So and also it's not so clear that more connections is always good, because we know that a big thing that happens in the development of the human brain is there's something called pruning. We're actually born with a lot of connections, and over time, as far into 20s, we are losing some of those, and that seems to be really important. In fact, some theses are thought to be breakdowns in the pruning process, like autism. People with autism there's evidence that they have more neuronal connections, and they didn't prune as much. So, there's our brains, Mads, they want to grasp a narrative. We want to be able to have a quick explanation for the world around us so that we can navigate it. And so we gravitate to quick stories, but they're often just not there. They lead us down the wrong pathway, and it's very hard. And what you said about how do we know this is sort of like, that's my mantra in my family. I teach my kids, always say, if somebody says something, just say, well, how do we know that? And you said that, like, what's like, where did you come to believe that? And it annoys people, but it's really important. It's really important. Otherwise, we just go down these pathways that the population is going to. And how many times in science have we been told one thing and then suddenly we had to do a 180 because they took a little bit of a closer look at the science and it wasn't true.
I'm super curious about what things that we today in 2021 believe to be true that we in 2030 are going to be laughing at. Just like the brain was like not going to be able to change at all after you became an adult. The scientific fact, meditation that was Eastern weird stuff, people like they were out of their mind. And now we're like, yeah, of course. And like we can actually see it now with our way of like monitoring things, right?
Absolutely.
So I try and ask as well in my podcast, because I'm perfectly fine with that we don't know everything, but just kind of understanding what's the hypothesis that makes us believe this to be true. So I interviewed a really interesting gentleman the other day, but he couldn't explain the hypothesis for why it would be true. So I'm not going to publish the episode, because simply like, then we need to have some kind of hypothesis to be like, we see these results. We haven't been able to prove it, but this is our hypothesis that we believe in some years, potentially we can test, or something like that, right?
Right. And in medicine, there's nothing wrong with saying, look, we don't know how it works, but we know it works, because it's much easier to prove something works. It's very simple. You test it. You test it against a placebo or something, and there's but the mechanism could take years down the road, and that's been true for many things in science, and we have to be comfortable with that.
Yeah,
because it's I think less damaging to admit we really don't know than it is to think we know and find out that we were wrong and we went down the wrong road. We wasted a lot of time. I think the doctors don't like to not know and tell their patients they don't know.
Yeah.
And
but I think that's such an honest answer. Just like we don't know why it works, but we've tested it on so many people. We see people that are getting this. It seems to work for them. And we haven't been able to identify a lot of side effects that wouldn't be worth it. So that's why that's our best bet right now.
That's right. There's also a psychological phenomena that goes by an eponymic name that I can't think of now, that when you start to, when you get educated about something initially, you believe you know a lot more than you actually do. And then over time, as you get, if you get really deeper into it, you realize your level of confidence in what you know actually goes down. And then if you keep going, it'll go back up. So I think a lot of people who, when you're in the scientific community and everything is looked at with a critical eye, and every time you write something in a paper, they're gonna scrutinize whether the statement was too strong based on the data. We're very conservative. We talk in certain ways, say, the evidence, suggests, or, but we don't say this is it. But I think when you get to the clinician, who doesn't have that culture, knows a little bit about the papers, but needs to work in the world and have answers, and they will have a tendency to take partial knowledge and kind of fill in the gap, because it's just easier when a patient says, so how does this work? You say, oh, well, it increases serotonin in the brain. So we have to be careful about that.
Yeah. But of course, there is also just like empirical evidence, like as practitioners that are seeing different things and seeing patterns. And and testing things out, and they don't always have the perfect computer brain to say like this, but they've seen stuff before, and like there's something here they start to recognize in that human part that sees potentially something they couldn't set, like these are these 5 parameters, but this is what seems to be potentially something that could work for you, right?
Exactly.
But so going back to TMS, how do we use that today? And like, what are some of the results that we're seeing now that we kind of understand part of the theory behind like how it works? What are the results that we're seeing today? Like, how are we using it?
Yeah. So the use of TMS is really growing. And by the way, what's interesting about TMS is probably one of the first treatments that I can think of. Maybe, I mean, I can't think of another one that was actually designed as opposed to, we discovered by accident. Like I was telling you about the antidepressants, and the antipsychotics were found that way, and the mood stabilizers were found that way. But with TMS, it was really like, okay, this is what's going on in the brain. We need to fix this. Well, we know from physics that if we, build a machine that will do that. And then we tested it and it seemed to work. So today, at least in the United States, and I don't think it's as prevalent as it is in Europe, but today TMS is really becoming another, foot of the stool of psychiatry, where we had one leg, the first leg of modern psychiatry, I think, talk therapy, which we know changes the brain, and then starting in the early 60s, we had medications that were a revolution, and I think TMS, or in a larger sense, neuromodulation, because you mentioned TCDS, that's another way of affecting the brain, and that does use very low electrical current, but again, it's a way of physically changing the activity of the brain non-invasively. So this whole neuromodulation thing is I think we're going to look back and say, the early 2000s were when that whole third option came into being. So today,
neurofeedback. Sorry, David, just jumping in. Where is neurofeedback in that spectrum? Because that's measuring your brain waves, and then you get audio and visual feedback to kind of condition the brain. Is that also in that spectrum, or?
I would say it's a form of neuromodulation.
Yeah.
So today, you asked about, for example, TMS. TMS is widely used for patients with what we call treatment-resistant conditions, like treatment-resistant depression, especially. So people who have failed a couple of medications, depending on the insurance company, some will set it at 4 medications, some will set it at 2. The FDA label is 1 or more antidepressants that have been failed, because that's how the studies were done to prove its efficacy. They took people. So what's interesting is, this was really positioned as a treatment for patients who failed the conventional, because I think that people who were developing it knew that people weren't going to start off with a treatment where they had to go into an office every day for 30 minutes for up to 6 weeks, and insurance wasn't going to start off by paying that. So they took people of that group who tried and didn't get response to several medications, and the efficacy of TMS is, when we talk about the efficacy and the numbers, it's important to note that this is a tougher group of patients, a group that we know from studies that if they were just given another antidepressant, their likelihood of benefiting would be very low, because we know that after 2-3 medications, the chance that a patient will respond to any additional one go down to 13%, and then lower and lower. So when we see reasonably good numbers, that's impressive, because it's selecting the tough group. So today, insurance companies in the United States widely cover it. For example, the VA, which is the hospitals for veteran military, they have purchased TMS machines, and they will offer it. And the American Psychiatric Association, puts it in very high in its, list of, in fact, it could be first line. Yeah. So it could be an option. It's not usually first line because, again, insurance won't cover it. And
how high were the numbers in the studies when you said efficacy?
Generally speaking, the efficacy, let's say for depression, in the studies were, between 60 and 70% of people responded, meaning their depression improved at least 50%. And about a third of those people completely went into remission, which, again, we know compared to what the alternative, doing another antidepressant, was much, much higher. So it's not perfect, but it is a tool that before it was there, we really had not many options except more medications or going in a direction that I call going nuclear to do electroconvulsive shock, which is kind of you can think of it as the first form of neuromodulation, but a very, very non-selective, where you're sending, a strong electrical current through the brain to induce a seizure and kind of just reset the brain. So that has a lot of side effects, and we try to avoid that unless it's really a matter of life and death. So now we have TMS and ketamine as well as options for people who aren't getting benefit from the first line. And now we have OCD, being established by the FDA as an effective smoking cessation. What's really interesting about the smoking cessation indication is that device targets the brain areas that are been implicated in all the addictions, because there's a common pathways. And to get approval from the FDA, you can't just do addictions; you have to prove each one. So they proved smoking. People who are addicted to smoking had much higher rates of improvement when they got the TMS versus a sham. So because in a device you can't do a pill, a sugar pill, but you have a device that sounds similar and it causes a sensation, but is not targeting the area of the brain. So we believe that that same protocol will be effective for other addictions, but we have to prove them one by one to get the approval.
And how is it looking with side effects right now?
It's great. I mean, it's so much better than the medications because, nothing is going in your body. You have this stimulation that's occurring in this target area, and we have a fairly common side effect of people kind of, getting this used to this sensation of this tapping. It's basically, but it's what's interesting. It's totally a phantom because there's nothing physically touching them. As this as this pulsing magnetic field passes through their scalp, it activates those sensory nerves, and so they feel their scalp. They don't feel anything in their brain because the brain doesn't have any sensory nerves. You can cut into the brain and be awake, and you wouldn't feel anything. So they have this tapping sensation that takes sometimes a little bit of acclimation, but people within two or three sessions get very used to it. And the one, strong side effect that is very, very rare has occurred a countable number of times in the 13 years that it's been out in the United States, and the literally millions of treatments that we've done, are possibility of the seizure while you're getting this treatment, while you're under the device for those 30 minutes or so. But that, as I said, happens very rarely. And it also, most of the cases when they've been investigated, there's been a reason. Patients, might have gone out the night before and really drunk a lot of alcohol and didn't tell the operator, or they had a history of seizures, or they were put on some new medications that lowered their risk, increased their risk for seizures in the TMS, was done. So it's usually something we can avoid if we educate people not to do this and to inform us. So much safer than I would say, not necessarily safer, but less side effects. Patients are always complaining to me about the side effects of the antidepressants, and so we don't generally see that with this.
So what's the big thing holding TMS back? Like, you have to go to a physician. Would it be possible to have a home device controlling it, or like, because?
Yeah. So I think that's a big part of it. It's a physical. It's like going to your physical therapist, but you're going every single day, Monday to Friday, for 6 weeks. So it's a little bit of that's kind of inconvenient. But they're working on home devices, and we are actually soon going to start a study of a band that's already approved for migraines. It doesn't stimulate the brain, but you wear it at home, and it stimulates some of the nerves, the cranial nerves that feed into the brain. So I think what's going to happen was, there's going to be other ways of affecting the brain. There's already in the States something called vagal nerve stimulation, which was a treatment that was found to be effective for seizures, for epilepsy. And basically, there's a pacemaker implanted that stimulates the nerve that's the main nerve from our body to our brain, and it stimulates it, and that would control, reduce seizures in people who had seizures and medications didn't work. But they discovered that a lot of those patients who had depression also got better. So now that is an approved another neuromodulation where we're not directly stimulating the brain like we are with TMS, but we're stimulating the nerves that go into the brain and change the brain that way. So it's just a fascinating new chapter in neuroscience.
And when you get the treatment, can you do anything else at the same time, or you just have to sit and relax? Or
so you'll be interested in this, and that's exactly what we're trying to figure out. So we have people coming every day to our office for at least 30 minutes, and we want to leverage that. What else can we do that will? So we're doing a study right now where patients are doing CBT in an app right after the TMS, and the idea is, we know that the TMS. I mentioned something called neuroplasticity. The idea that the brain has flexibility to make new connections and change, and TMS kind of enhances that. And especially right after a TMS session, there's a kind of a golden period window, maybe of half hour, where there's particularly good neuroplasticity. And so the idea of the study is, if we would have people do therapy, cognitive behavioral therapy in that window, it might benefit from that neuroplastic window. So the study is looking at people who immediately after their TMS session will do the CBT therapy versus sort of several different kind of app controls where it's not CBT. So yeah, I think a big area for further development of this is how to combine it with other things to get even better results. And something that I think about a lot, because I have these patients who, you don't normally have patients coming to your office. You can't usually convince them to come to your office for when they're doing this treatment. They're willing to do it because they know that's, and then you just want to, you want to use that in some way to advantage.
But that half an hour, can they do anything else at the same time, or only like after, or like can they actually read a book, watch Netflix, or work?
Yep. They are totally, but after a few sessions, they're completely unaware of the sort of the tapping sensation. There's a tapping sound, and so they're often on their phone. Sometimes we see them meditating. I go in to say hello, and I just back away because I see that they're kind of like in a very meditative space. They can read. We've had patients who've read books, and we don't know what's the best thing to do at the time. But I will tell you something really interesting is for the OCD and for the smoking cessation studies, it was discovered that that what we want them to be in is in a state of mind where their symptoms are activated. So, for example, with OCD, we find out what each patient's specific sort of obsessions are. So let's say, we have a patient who it's all about cleanliness, and they have to wash their hands, and they're very uncomfortable if they touch something. And then we, before each treatment, we actually kind of get them into an area of moderate discomfort from their OCD, because the preliminary studies showed that the TMS works better when they're actively experiencing their symptoms than when they're not. And for the smoking addiction, we're really quite cruel, but we have people hold a cigarette, smell it, roll it. They can't smoke it, and so it stimulates that addictive craving, and then we do the TMS and zap those areas. And the study's shown that if you do it with or without that, you get benefit both ways, but you get more benefit. So I think that's fascinating. It's sort of like, putting the brain in a certain optimal state, and then you treat it, So that's, I think, another cool aspect of what we're learning about the whole, neuromodulation of the brain.
Yeah, it's extremely fascinating, David.
Yeah.
It's an interesting field you're sitting in.
I feel very, very lucky.
and we didn't even get to ketamine yet. I'm not sure how hard your time is.
Oh my goodness. Let's do it.
Cool. So David, ketamine, I read a study, I think it was some years ago, where it had these insane results. I think it was with depression, or people that were suicidal and so on, where they had like ketamine treatment once or twice, and then they were suddenly good. It sounded too good to be true and almost like magic, but like, where are we with that today?
Yeah, you're spot on. The first studies that came out were small studies, and they gave ketamine. Ketamine is a drug that's been around 50 years as an anesthetic, still used as an anesthetic because it's incredibly safe and effective. So it's still very popular. But in the year 2000, a paper came out out of Yale showing 7 people with treatment-resistant depression got infusions of ketamine and or a kind of a placebo. And during the ketamine phase, these patients had crazy good rates of improvement, which again, in that group of people, so it's a tough group. If you get 20% of the people getting rid of their depression, that's good. But this was like 70%, I believe, and also what was crazy was that it was fast. And in psychiatry, we generally don't have fast treatments. We, if they are going to work, we say, you're going to have to wait weeks. But this was like, people were feeling it, the measurement was at 24 hours, the first measurement, and there was already a very strong separation. What you said about it being too good true, that was exactly my reaction. I was like, this is too good to be true. And we know in science that you can do a small study and get remarkable results. And often I've been in that position where I've had done some studies and they were really remarkable, but then they just didn't pan out. When I tried them again, other people tried them. It wasn't as good. So in science we generally are skeptical. You have to really prove to us something that is so different in terms of its capacity to do something. The more the more outlandish the results, the more you have to prove it. So I really I kind of filed it away, and I said, yeah, probably too good to be true. 6 years later, there was another study coming out of National Institute of Mental Health, where they did the same thing, larger group, and they, believe it or not, they got even better results. So when this paper got published in 2006, I was still honestly kind of skeptical because it was so different than everything. And it's not like it's a brand new drug that was developed. This is a drug that's been under our nose for 50 years. But I thought that we're in such a need for something really new and effective that I needed to find out really if and I didn't want to wait another 6 years for another study. So I convinced the powers that be at UCSD, and it wasn't easy. I can tell you, they're very, institutions are very conservative, that they should let me give ketamine to patients with treatment-resistant depression. Now, keep in mind, depression is, a lot of people think depression is, oh, well, you're sad, but it's more than that. I mean, people die. It's there's in the U.S. 45,000 people approximately, depending on, fluctuates from year to year, die from suicide. Most of those are from depression, as a result of depression. People, have just people who don't commit suicide often have no quality of life. They're not productive. They're in bed. They lose family members. They're just a great impact. So we have a lot of people who have this devastating disease, and the treatments we had were not good enough. So there was a rationale to try it, because everything we knew about ketamine was that it was safe. Granted, we hadn't given it for depression, and we hadn't given it repeatedly, which it seemed was necessary to get for most people to get the effect. So anyway, UCSD, agreed, convinced them. And in 2008, I started giving patients the ketamine because I had to know for myself whether this is something I should really, embrace or move on, because I was desperately looking for something better than what we had. TMS would come out, and that was really exciting, but we needed more. And it was really, I saw that this was like nothing I've ever seen in my career, and people were just transformed very quickly. And over the last 15 years, there's been a slew of well-controlled studies that have replicated the result. And in fact, there's very few studies that were not positive in ketamine, which is unusual, because usually if you take an antidepressant and you do 4 or 5 studies, you're going to get one that didn't separate from placebo. But this is a very strong effect. I think there's very few people who don't now, even in the establishment, very conservative establishment, recognize that ketamine is a breakthrough for depression. And then along the way as well, we discovered that it was more than depression. It was PTSD, anxiety, OCD. We just published a case report of 4 patients that we treated with an eating disorder, long-term for about a year. Their eating disorder and the depression that goes along with it got better. And so I think it's here to stay. It has its limitations, but it is really, really, the first new mechanism drug in 50 years for psychiatry, and it is really different in that we not only in how effective it is, but like I said, the dramatic nature of the improvements that we can see. Sometimes in one treatment, although that's not always the case. And so if people read about that, because if a journalist is going to write about an example, they're going to write about the dramatic example. So that a lot of patients say, expect that it's going to be just their first one, but it can be, and that's something we don't see. So so today I think ketamine is definitely a brand new important tool, and what is particularly good, probably the lowest hanging fruit, if you will, for what it does is improve the suicidal thoughts and urges that people with severe depression often have. And one of the ways it's revolutionized psychiatry is that when you're a psychiatrist and you have a patient that's really struggling with these thoughts, you have patients who will drive by. In San Diego, there's a bridge. It's not as famous as the Golden Gate Bridge in San Francisco. We have the Coronado Bridge, but they'll drive by it, 2 or 3 times a week just to play out in their mind, So when you hear that, you get very scared for a patient, knowing the high rates of the people that they do commit suicide, and really, when you get to the point where when you feel a patient is potentially an imminent risk to themselves, as psychiatrists, at least in North America, one of the few options we have is to hospitalize them. A lot of times they don't want to do that. They don't feel they want to do that. And if we feel it's a matter of life and death, we'll do it. We have mechanisms for doing it against their will, which is I really loathe to do, because it's never patients feel very upset about it, and so there's a lot of cost in terms of the therapeutic alliance. So I really would only do it in really extreme cases where I thought that if I didn't do it, the patient might take their life in the next 24 hours or so. But with ketamine, for the first time, there's an alternative, and there's an alternative is to do a treatment for ketamine, and more times than not, when I've done that, it's prevented the need to hospitalize them, which is like mind-boggling. Just mind-boggling.
And what's the hypothesis right now, or have we been able to see this is what happens in the brain, or what are we seeing? Why this is working so well?
So as we spoke before, we have correlations.
Yeah.
And you can think about it at different levels. From a pharmacological level, ketamine works through a completely different set of receptors than the traditional antidepressants. Ketamine doesn't bind to a monoamine receptor. It binds to a receptor called a certain type of glutamate receptor. Glutamate is, like serotonin and dopamine, another chemical that is used by the brain to communicate between brain cells. In fact, it is probably the most ubiquitous, the most prevalent chemical in the brain. But our medications generally haven't tapped into that. Drugs that until now have modulated that. So it binds to something called the NMDA receptor, which is a subtype of a glutamate receptor. So there's the pharmacological aspect. Then there's the sort of brain function level, and we know what happens with during ketamine is that there is a very different pattern of brain activation that we see. Normally, when we are not doing anything that requires a lot of cognitive concentration, and we're sort of, we're idling, like our brain is idling. The brain doesn't actually just kind of go to sleep like your computer. It actually, some areas kind of shut down, but then there's certain pockets of areas that are connected by a kind of a circuit that become active. And we call this the default mode network. It was discovered around 15 years ago, because we always thought that if you're not doing anything, you're not watching something, you're not concentrating on something, your brain kind of just goes to sleep, like you're setting on your laptop. But we then discovered that it doesn't. It goes into a different mode, this default mode network. And there's a lot of thinking about what the default mode network does, but the current belief is that at least part of its role, it creates this psychological continuity of ego, of who you are. This unitary being that Mads today is the same Mads that was a child decades ago. That you're the same person, that you take up room in space with the body. And during ketamine, that default mode network, we don't see it standing out in activity, but rather there's a wide, brain-wide activation. And so that could be part of the therapeutic effect. Some people have suggested that what it does is it allows us to get in touch with ourselves more, by all the areas of the brain being active at once. An analogy might be that if the freeways were shut down, are you in Copenhagen?
Yes.
So if the freeways are shut down in Copenhagen, and you had to go around in your car, you'd have to take all the we call them surface streets, and you'd suddenly get much more familiar with your city, because you go through neighborhoods that you never go. You just pass over them, and suddenly you just feel more connected to your fellow citizens in the neighborhoods that you never really got to know. So that might be part of it. And then the next level we can talk about is the psychological level, which I think is really important, because one of the things that happens with ketamine treatments that is just so different than almost anything else in psychiatry and medicine, is that there is an experience that takes place when you give the medication. And that's why the treatments are generally done in a clinic, observed. There's an experience, a mind-altering experience. You can call it psychedelic, for lack of a better term. But people will go through a period of what we call a non-ordinary state of consciousness. And we think, and most patients will often connect their getting better, their depression getting better, their PTSD, to that experience in some way. And so that's a fascinating, idea, and so different than the traditional, Western paradigm of medicine, where a person's experience of the treatment isn't that important. It's the medicine, getting to the right place, doing the right thing. And so, we tell people, if you take this pill, you can take it before you go to sleep. It's going to go in your body. It's going to fix whatever needs to be fixed. You can be in a coma, and you can get doctors can notice that you have a fever, and then they culture your blood and see, oh, you have a bacterial infection. They can give you an antibiotic intravenously, and then the infection can be cured. You can wake up from the coma a week later, and you never knew that you had the infection. You never knew you were treated. You never withdrawal. We didn't need you to be present. We just need your body and the medicine and a way to get it in. But here, with ketamine, if this is in fact the case, that the experience is a key part of the element, here patients need to be present, and their state of mind plays a role, and their how they're going into it, with what intention, which might explain why we didn't for 50 years have people routinely wake up from surgeries when they got ketamine and say, oh my God, I think my PTSD is gone. Or, so we've given ketamine to millions of patients, certainly hundreds of thousands of patients with PTSD and OCD and depression and anxiety and so forth. But we didn't kind of notice, like we did with the tuberculosis drug, and that suddenly we were getting this side effect. I've heard some cases of that where I've had patients who said they went to a procedure and they got up and their anxiety was so much better, and they went and they asked the surgeon, what did the anesthesiologist give me for that procedure? And it was like ketamine, so, but for the most part, we didn't see that. It was only when we used lower doses and people stayed awake and experienced it that we had this. So what this means is, if we want to get the most out of ketamine, we have to now pay attention to the person's state of mind. So we have to prepare them for it. We have to put them in a comfortable setting where they're relaxed, and the decor is important. The staff is important. And those are things that, didn't matter before. And so if you are a kind of doctor that likes to just fix things without having to, pay attention to let's say, if you like fixing bones and patients is out, you don't need to talk to them, you fix their bone. Well, you won't like this kind of medicine because it's kind of messy. You have to and people come in even on 2 different days feeling a little bit different and having experienced something different, and so there's a lot more variability in their experiences when they come back. But it's a whole new world, and because of ketamine, I wouldn't say not just because of that, but at the same time there was also this, as you know, this renaissance, if you will, of more classic psychedelic. Because a lot of people are surprised when I call ketamine psychedelic, because they think of it as an anesthetic, even though it's known as a dissociative anesthetic. A dissociative means it kind of puts you out of your body. But it actually has a lot of the classic features of, let's say, LSD or psilocybin, actually. But now psychiatry is seeing all this excitement because we have drugs that everybody associates as psychedelics, like psilocybin, which is the active ingredient in psychedelic mushrooms or magic mushrooms, MDMA, which is the active ingredient in ecstasy. They're actually being developed under FDA guidance. In fact, the FDA has given them a status of accelerated development because they know there's such a need in this field, and these things look so good. And they're looking really promising. And in some ways, they might have advantages over ketamine in that they may last longer than ketamine, because with ketamine we do need to repeat. And that sometimes is problematic because it's not typically covered by insurance. So,
and how often do you need a ketamine treatment? Like, what is it looking right now, and how far are we with the FDA approvals with ketamine for different things?
So, with the repetition, it varies from patient to patient, and we don't know until we've explored and find the dose that works the best and the longest, and then we have kind of a patient's duration. So they may come back once every 2 months, but we've seen where people have had the most amazing benefits, where they said, in my 20 years of struggling with depression, nothing has worked like this, and I feel like I'm remembering what it's like to be normal. But sadly, it may only last for 5 days, and nothing we can do can make it last. So it's kind of one of those unfortunate things. Now, generally, that wouldn't be such a problem if you had to. It's a little bit inconvenient because you have to come and get it done, but it wouldn't be a problem if insurance in the United States would cover it. But it doesn't, and the reason it doesn't is just a system issue. The insurance companies, as a rule, only will cover things that are FDA approved, and the FDA will only approve things. They don't go out looking for good things to approve. You have to apply and do very expensive studies, even if it's already been kind of demonstrated in other studies to their level of scrutiny. And those cost hundreds of millions of dollars. And because ketamine for depression was already in public domain, old drug was already kind of out there. There was no patent, no company was willing to go and get ketamine approved for if they're not going to be able to control the rights, because the next day a company can market it generically. So we've got this breakthrough medication that could make a huge dent. It's actually, the medication itself is quite inexpensive because it's generic, but the treatment is costs a little bit because it has to be monitored and, in a setting and so forth. But the FDA, but patients can't get insurance coverage, so we're limited to only those people who can do it, privately. And there is a product now from Johnson & Johnson called Spravato, which is a kind of an approach where they said, what's the minimum we need to change ketamine infusions so that it's different enough we can get a patent, but it'll be close enough that it's going to, we can be pretty sure it works. So what they did is they took ketamine and tweaked it to S-ketamine, which is a very probably not inconsequential modification. And then they also proposed S-ketamine administered nasally for depression. And that was good enough to get a patent. And they spent, I've heard, like $350 million to do several studies, and they got it approved. Although it was controversial because the nasal spray doesn't produce the same blood levels, and the effect sizes that we saw in the Spravato pivotal studies were much smaller than the ketamine studies, and in fact, some of them failed. But the FDA recognizes that we need ketamine, such a breakthrough that this is as good as we've got for now, and they approved it. So we're starting to make some progress. So Spravato is not exactly ketamine, but it is ketamine-like, and it is being covered by a lot of insurances. That's a big breakthrough because, ketamine can be wonderful, but if you can't access it, it's not wonderful for you. So Spravato may be less effective, but if you can access it, that's better than a drug that's better that you can access. So we're making some progress there, but I think what's really exciting is that if you look at the startups, and I know you're very interested in startups. I think the investment world sees that there's a disruptive a situation occurring in mental health, and these new generation drugs that work through creating an experience are going to be a paradigm shift. And I think there's huge influx of interest by entrepreneurs and investment by investors to develop multiple different psychedelic drugs and to develop apps that kind of will facilitate the treatment, and to think about all the kind of the landscape of doing psychedelics in an efficient way, because it is such a different. We're going to have to figure out how to do it effectively, because a trip that's 6 hours long with psilocybin, and right now the paradigm has been 2 therapists sitting in, is not very efficient. Let's put it that way.
It costs money.
Costs money, yeah. So we're working on seeing.
It's definitely a scene that's attracting a lot of capital right now. If we're just seeing like the result seems to be good, and it's interesting as you're saying, like a general problem with like ketamine is like a generic drug now, so there's just no interest in actually, or no incentive to pay all that money to do the research to get it approved, which I think is a challenge with many of also like the natural things that we discovered, that we make a drug that has the same kind of effects as you're saying here, but it might not be as effective as the natural thing, and we could have just given the natural thing much cheaper. But now we got a company that can kind of change it a little bit, and then they can get it approved, and they can start marketed, right? So it's a general problem we have in our healthcare system. Yeah,
I wish the governmental agencies would recognize this problem and send out a patch, to fix that, because these are all, like, for example, the FDA approval process came out of good intentions, but it created its own barriers in some way, kind of odd barriers, like we were talking about with in the patent system. And when you put it all together, you have this unintended consequences of a simple drug that could make a difference, but just can't make it, widely distributed or economically feasible. And I wish there was, rather than just, kind of creating these alternatives, that there would be mechanisms where the incentivize people that they go ahead and develop these more simple approaches that would still be feasible and not just lose money on them. So maybe that'll happen.
Sure, I hope so.
Me too.
David, time is running. I would love to probably get you back on the show one day to talk more about psychedelics and like where we're going and like what is the future and like what steps do we need to go through to get this more proved, and both like in a medical sense, but also for like normal people, because there's the whole microdosing and like this so many things that's opening up. I'm very conservative because I want to see things, especially with my brain. I don't want to risk anything with my brain. But I'm so curious about all the things that we can actually do to enhance our brain as well. But I think we can talk for hours more to get deeper into that.
Yeah, I certainly could. It's fascinating, and it's a very exciting time in the field. And I'd be happy to come back and fill in the gaps.
That'd be fantastic. Where can people find out more about you?
They can visit my clinic's website, which is the clinic's name is called Kadima Neuropsychiatry Institute, and the website is Kadima, N like Nancy, P like Paul.com.
I'll make sure to put that in the show notes. Are you on any social media where you're sharing, like Twitter, Instagram, LinkedIn, TikTok, doing dances about the brain, or
not as much on those things yet, but LinkedIn, Facebook, like we can add those links as well.
Sure, I'll make sure to. I always end up asking the guest like 1 to 3 advice about how to live a happy, healthy, and meaningful life.
Well, that's a pretty ambitious. I think for me, first of all, I mean, I would say that if you suffer from a diagnosable mental illness, you should take heart in the times that we're in and the exciting things that are happening. So I think I deal with a lot of patients who hope is a big issue. It's very hard to be hopeful because they've been trying to get better for so long, and they try one antidepressant or one medication after another. But I tell them this is if you're going to have a mental illness, it's finally a really good time, or a good promising time, because within the next 10 years you can expect to have really new things. So I think being aware of what's out there. But I think that we do know that for the general people, a couple things, vigorous exercise, meditation, socialization. We are social people, and generally that it's our network that kind of is a mediator of our mental health. Those are the things that one needs to pay attention to, and the research has shown is a buffer. When I get patients well, I say you don't want to rely on ketamine or TMS. Now that you're well, you need to do the things that we know are going to be like a layers of body armor for you. That you couldn't, when you're so shut down, you just can't exercise. It just feels like it's like they're climbing Mount Everest just to get out of the house. But now that you're better, these are the things that are going to keep you better. You don't want to rely on pharmacology or something like that. So I think that we are definitely seeing the right foods, exercise, meditation, and your your social network, nurturing that, being part of a community. One of the things that has occurred to the human species is, and I think it's a big reason why mental illness we see in depression increasing, especially in countries that are developing, from third world to second world to first world, is that we went from more tribal, let's say, family-oriented groups where everyone knew everybody and everyone supported everybody, to these more impersonal, highly mobile societies where you may be separated from everybody else, and raising, I always think about young children, young mothers. I have a daughter who is a first-time young mother, and I remember when my wife was a first-time mother, when we had left our family in Canada and come to the United States, and and it's very difficult being isolated, and it's not an easy time when you have a young child. And 150 years ago, most people would have been in a small town or village, and they would have had their grandparents there and their siblings and neighbors, and you had somebody to give your baby to for several hours, and we've been stripped of all that sense of network, and I think that has made us more vulnerable to anxiety and depression. And we don't enjoy the simple things anymore. It's all about achievement, and that never ends. So I probably I shouldn't talk, because that's I probably fall. My family would say that probably I fall into that category. But for me, it's not stress. I thrive off of that. But that's not usually the case. So we need to have a little bit more of a balance, I think.
I think.
So I don't know if those are three recommendations or one very long one.
It's definitely useful, and it's something. It's interesting whether I talk to psychologists, medical doctors, athletes. It's many of the same things people come back to. It's enjoying the small things. It's
Absolutely.
a good community. Yeah. It's doing some exercises, meditation. It's being curious. And learning new things, like you're saying, being hopeful. If you're in a tough spot, time will often come with new solutions, and you will feel better.
Right. So, and gratitude, I think, is also a big thing. That's something that's not easy for us to hold in our minds, because we tend to be more aware and affected by the slings and arrows that we experience, and we kind of get used to all the accomplishments and blessings and so forth. They become the background, and so then all we're aware of is the hits that we take every day, and so it's really important, I think, for us to take a step back and think about how lucky we really are to live in this time, with all the kind of the news tends to emphasize the margin at which the good ends and where our threats are. But in relatively speaking, I mean, we've come a long way in many respects, and everyone has personal reasons, I think, to be grateful.
I agree. David, I really enjoyed this talk. It was kind of like I predicted. Time would fly really fast. I think this is actually the longest episode. I normally try and keep them to like maximum hour, but it was too fascinating to talk to you about all this stuff. And I still feel like I'm missing another 5 hours to just dig into all of these subjects. But I really appreciate you taking the time to get on the show.
My pleasure. I appreciate you creating podcasts like this that are so important, and inviting me.